Association Heart Association is starting to make a report on it. Now, the other problem to think about, if you're thinking about just have the paramedics take everyone to the right place, half the strokes walk in. Now, they're less likely to have a large vessel occlusion, but some of them do. We've seen large vessel occlusions with NIHSS scores of 1. I had one in last night in Fresno. Her score was 2. And she opted to not go all the way for transfer. So walk-in strokes have to transfer under the best of circumstances. So they've developed models. There's even an app now. In fact, I've got an app on my phone that'll tell me if I have a stroke, depending on what it is, where I should ask the paramedics to take me. But the thing that's a problem with them is they don't account for large vessel occlusion frequency, accuracy, and so on. There's a group up in Calgary that's done a lot of work predicting this, and they've started to dial in things like, well, what's the door-to-needle time at the closer hospital? I was talking to one of the authors, and she said they ran this in Japan. Japan asked them to run it, and they actually found out that the app said that if this patient had a stroke in this hospital, that you should actually take them to the other hospital because their door-to-needle was so much better than the other one. And even though they were in the emergency room, you should pick them up and take them. They couldn't believe this until they ran the numbers and realized the difference was the door-to-needle. So, here's the other thing that's been thrown out there, and I think there's been some discussion in Sacramento actually. Just put the emergency room in the ambulance. So the first choice is to make paramedics stroke neurologists. And the second choice is to pick the ambulance, the emergency room up and move it. So they've actually got these really cool slick ambulances that have CT scanners in the back, and they've got video capability, and if you're in Houston, Dr. Grata's riding around in the back of an ambulance to treat you, I think. It's pretty cool stuff. The problem is I'm not sure how practical it is. It's being used in Berlin, kind of a big sprawling place. It's been used in a variety of places, different ways to deploy it. I'm not sure it makes a lot of sense if you look. It's really cool, but I'm not sure how much sense it makes because it's a little hard to justify the cost. They only treat a couple people a week at most. So how do you justify that cost? And it has to do a lot with geography. I think there might be places where it does make sense, but you have to think about time to treatment, geography, and so on. What's your deployment? Do they go out to every stroke, and so on? And again, don't forget people walk up with strokes, so it isn't going to benefit everybody. So my proposal, I think, if I had my wishes, I would make a system where every single hospital can treat people really fast, like less than 30 minutes. Because that takes away the idea that you can really get them treated quickly. And then I would get the transfers really quick and easy. I think they should be in and out of the door in less than an hour, including the CT angiogram, including all other perfusion. And once they get to the other hospital, you haven't lost any time because if you're pre-notified, they go straight to the angio suite and you can treat them within 15 minutes. So just looking at the whole picture, this is my ideal wish because everybody benefits, including patients that walk in. So, what are the solutions for that? Well, we talked about an Uber ambulance idea for CCT. CCT rigs, everybody's got their contracted one. What if you could just order one on Uber? Maybe they'd come faster. So Uber ambulance. If anybody knows the Uber guy, I want to talk to him because I think we've got an Uber ambulance option here. Because that might be something you should think about, but you still got that 20-minute thing. Streamlined CCT, a scoop and go idea. This has been used in trauma, and we've tried to kind of get that idea that you sign them out on the way in. There's a very abbreviated checklist to get them out, and we had a variable. We had a meeting with the CCT people. They seemed excited about it, but I don't know how consistent it is. You can also avoid the CCT altogether. We talked about the ALS, the RN, we talked about 911 and a drip with a waiver, and now I want to talk about tenecteplase, because this is my big wish, and we may go there. I'm trying to talk my team into this. So you know what tenecteplase, right? This is TNK, and the advantage to TNK is it's a one and done. There's no drip, there's no CCT rig. It has largely supplanted alteplase for cardiac cases, for MIs. Okay, so full disclosure, totally off-label at this point, right? Mary's sitting there going, oh my God, he's talking about it. So this is what the data is. There's a bunch of studies that are starting to come out, and there's been, all of them have looked at, are trying to get, right now they're trying to get a superiority, but there's basically, they're all non-inferior. So tenecteplase seems to be as good, and in fact, most of the study, in fact, all the studies have favored tenecteplase over alteplase for effectiveness, which is super interesting because not just because do we need a drug that's more effective, I don't think so. Do we need a drug that avoids the transfer problems? That's where Extend.IA came in. They looked at it for transfer patients. So, I mean, basically it's non-inferior, it's possibly superior. There was a big discussion at the International Stroke Conference, sort of pro and con this year. And the argument was it's probably better at dissolving large clots. We heard the problem with penetrating alteplases. It seems like it might be better based on some cardiac data and basically looking at some of the pharmacology. It may have a lower bleed rate. We don't know that at all from the stroke literature, but the cardiac literature sort of hinted at that. The main argument that people made against it is it's not better than alteplase, so why would we switch from something that's FDA approved and tried and true to something that isn't? And the answer is, well, it's not just about whether it's better, it's about whether the system is better. And there's studies looking at this, ongoing, looking at superiority that haven't been published yet, but they're looking at it. The other question was dosing. Different doses have been used, but it looks like people are settling at 1/4 milligram per kilo. So kind of IV alteplase is actually a little more expensive, not a lot, but a little bit. You need the CCT in the infusion instead of the one and done. There's no transfer of pumps and lines and all. It probably has a better rate with large clots. It probably has a lower bleed rate. It's off-label. So summary, current AHA guidelines say take them to the closest facility, and if there's a lot of places, it's not clear that bypassing makes sense. This is current guidelines still. So I was asked to talk about prevention of the next stroke because RightCare is about prevention. I think we don't want to forget about this. After somebody has a stroke, you sure as heck don't want them to have another stroke. So just quickly thinking about it, everybody benefits from 6 interventions. Well, almost everybody. If you smoke, if you don't smoke, you don't get the benefit, but at least you don't get to get dinged for smoking. So everybody should be on a statin. Why? Because statins prevent strokes. Not because of the cholesterol, not because of lipids, because it prevents strokes. There's very good data. And in fact, we published data that the sooner you give it, the better you do. So everybody goes out the door on a statin. Everybody needs better blood pressure control. In fact, I would argue that if you can stand it, you should be on blood pressure medicine. Because the thing is, it's not about where your target is, it's the idea that lower is better at kind of any level, and that's a big area of concern. And everybody should be on some kind of aspirin or clopidogrel, or you could make a case for a combination based on a bunch of studies, but it gets a little complicated. We don't have time to get into that. And everybody should be on a heart-healthy diet. You get a 30% reduction in your stroke risk with statin, about a 30 to 40% reduction with blood pressure, about a 30-ish% reduction with aspirin, maybe 20, and a 30% reduction with a heart-healthy diet that's high in fruits and vegetables, 5 helpings a day. You get a 30% reduction with a half an hour of exercise a day. And if you stop smoking, you get at least a 50% reduction. So you should not only, and then the problem, of course, is secondhand smoke. So not just stopping smoking, but shunning smokers. And then for some people, carotid surgery for occlusion. So that's something else we're always going to look at. The advantage of doing a CTA on everybody is you know what their carotids look like. Some people need anticoagulation for Afib. We'll talk briefly about it. Sleep apnea is a stroke risk factor. There's some evidence that treating that can be beneficial. If you've got PFOs and you're young and it's cryptogenic and, there's a few people that benefit from closure, but not all. So, you might consider, well, certainly carotid imaging is pretty standard for stroke workup, super helpful. Because if you've got ipsilateral symptomatic stenosis, you should have surgery. If you have asymptomatic stenosis, we can have a long discussion about whether there's still any role for surgery if it's asymptomatic. One of the things I think that gets underdone is 30-day or longer heart monitors, and one of the things I think that gets overdone is echocardiograms. If an echo is routinely part of your stroke workup, you've got to rethink your stroke workup because it doesn't really make sense unless you've got some other indications like an abnormal exam and abnormal EKG. But you can make a much better case because the yield is higher looking for cryptogenic atrial fibrillation. And then, in some cases you need to do a coagulopathy workup. For example, my 14-year-old last weekend that had a stroke. How about that? I'm still sort of shaking from that. 14. In Sacramento, actually. So, in conclusion, acute stroke is treatable and preventable. Time is critical in any kind of stroke treatment. I think we got to really emphasize the notion of a system of high-functioning primary centers with the ability to transfer. You can argue whether the CT perfusion should be done at the receiving center or the sending center, but I would argue every primary center ought to be able to do a CT angiogram because that really is the screening kind of thing. I think transfer is the next big thing. I don't buy that you can't transfer people quickly. There's got to be a better answer than that because it benefits everybody. And then I think we need high functioning CSCs, so you can't have the comprehensive center say, well, I've got to check for a bed, I'll get back to you. They just need to say yes. That's what I want because I'm on the other end of the phone. They got to have enough volume to be good at it, and I think they need excellent treatment times and results. But if you did all of this, which I don't think is undoable, we'd have a pretty fantastic stroke treatment system.
Thank you very much. We have time for questions. Let's from the audience first. Any specific things you would like? Yes.
Sure, for Dr. Klingman, with your 42% treatment rate for alteplase, do you see, what is your complication rate with that?
Yeah, so the bleed rate is, well, it depends on the year we look, it's about 4% bleeding, symptomatic bleeding. So it's no different than it was before. Most of the reports say 6%, we've been at about 4.5%. We quote people 5% because it's been about 4.5%. And people always say, well, gosh, how many mimics are you treating? And we're treating a few. We looked at it, it's a pretty low number, but there's a few mimics that get treated. The nice thing about treating mimics is they're much less likely to bleed.
Great. Thank you.
Yes.
Great job, everybody. It's Dr. Klingman. So I have a question, and looking within the Kaiser system, but also maybe through the other systems, what can we learn from cardiology? Because it seems like when we have a hot MI, we can get those patients out the door a lot quicker than the strokes get out the door. And our numbers needed to treat are actually better with thrombectomy than they are for single cardiac.
So that's a good question. The first thing we can learn is that neurologists probably aren't paid enough like cardiologists. But I will tell you that there's a big difference there. I don't know the answer. I'm not 100% sure. They've got a longer system. I mean, the deal is, when I went into neurology, we admired diseases rather than treated them, and many of our interventions have come from cardiologists that have been doing it for longer. But I don't know. I mean, I think we've done a tremendous job redesigning the system, and I think the answer may be to continue to look at what they do. I'm not sure they're that much faster on the transfers is the problem, because as soon as you pull CCT into the thing, it takes a while. Thoughts?
Yeah, I guarantee transfers are not faster because we run the PCI program for the state and transfer. We have the same problems transferring just from Roseville down into Sacramento, where it's taking over an hour. It takes a half hour for the rig to show. There's a 20-minute, as you say, setup time or half hour. And then, depending on traffic, it can be another 40 minutes just from Roseville down to one of the core hospitals here in Sacramento. So we work on this all the time. I have a pile of cases of extended transfer for STEMI that had to go to the operating room at a different hospital, which are all violations of our over 1 hour transfer time. So we have the same thing. I think one thing you do see, though, is that STEMI treatment, primary PCI, really started 10 years ago. So we're at least 10 to 15 years ahead of the time. And we have bigger volumes, and so the system is greased a little bit better through there. So when they come in, there's no questions. They go into a protocol, and they're moving quite fast. This is new for stroke to be doing this. So I would assume we'll get further improvements and door-to-bloom time, door-to-imaging time, and other things that as they come along. One of your big questions is, other than getting the scan, is to see the neurologist. And you can't, we actually have a cardiologist who sleeps in the hospital so that they're there when those patients come in. That's a lot to ask for neurologists to be actually in the hospital all times. You mentioned that you have a video for it. Is there any way that we could eventually replace a neurologist with artificial intelligence and you could have a monitor, RT2T, that would sit there and go through that and come up with an algorithm?
So no, it's a super interesting idea because there's a couple things cardiology has that we don't. One's an EKG. We got no marker that's equivalent to an EKG. You do an EKG in the rig and have a pretty good idea somebody's having an MI. We don't have that. And then you've got a blood marker. We have no blood marker. So it has to actually be a physical seeing the person, which has led to a lot of complexity. That's why you see teleneurology exploding more than cardiology. The other problem is if I had the guy sitting in the hospital, he would treat at a large center a couple people a week with alteplase. So it's really hard to justify because, as you said, the volume is different. Now, about artificial intelligence, they've been working on AI for doing like reading the CT scanners because in some cases the harder thing is the neuroradiologist, which I get. We like I said, we've got this luxury of having neuroradiologists reading all of them. We've talked about whether you could get the neurologist into the rig. That would be interesting. By video, if I'm doing video to the ER, I could do video to the thing. Would that improve the ability? Well, you might get more to 50%. You might get more to, they're all acute strokes, and you still get it to 50%, it's still a lot better. There's some technology that's being looked at to put on the person's head that would potentially say, is there a large area of reduced blood flow? I've looked at these. They're not that impressive yet, but I think we may get to that, where you could say, look, this is likely going to be somebody with reduced perfusion in a big area. Maybe we can send them.
You're right. For cardiac, we have 2 non-invasive tests we can do right away, non-invasive. We can do an EKG and see the electrical activity in that area. And I can put an echo on and in 2 minutes tell you whether that wall motion is moving or not, whether it's getting perfusion or not. And that's all non-invasive without doing anything. I think one of the things that we could look forward to is there a threshold where we can get a non-invasive test to tell whether there's an LVO or not in that situation. And whoever comes up with that, let us know, because I think we would be able to arrange funding for that. Other questions? Yes.
Just a quick one for Patrick related to Valenza. Any thoughts on where we're at in this area for CCT medics?
I don't have any thoughts on that right now.
Any opinions?
No, we do allow, SSV EMS does allow for the 911 to be used for the transport of patients. We currently do not have any CCT paramedics. One option as well is to fly them with a helicopter that I spoke about. That has a round trip of roughly an hour from time liftoff, as you know, to land in the next facility with the patient. So that could be a quicker destination for the patient than trying to wait for a CCT ground transport. That I'm not sure if they've thought about or not, but they can utilize 911, and I'm not sure about the paramedics.
I think we have Dave Magnino.
David Magnino is our Sacramento County EMS coordinator. Go
Yeah,
ahead.
it's funny you should ask that because my agency was approached by one of our private providers first part of this year, asking if we would consider running a program, the CCTP program. We were working for it. We were going to the board to ask for a new program to do that. Required us to ask for funding, in other words, the permission to charge that provider or any providers that wanted to start in that program. And we were turned down by the board of starting that program because it was 100% funded by the providers. And because I don't have any extra money in my budget, I couldn't institute that. But it's not a dead issue. It's dead for this coming fiscal year. Because I do know that there are several of our private providers who are very interested in doing it. And they're even willing to send their people back to Maryland, to the university back there that teaches that program, and then also brings the University of Maryland out here to run courses out here on their dime. So it's dead for this fiscal year, and
This is where we need to get our hospital people involved.
we're working on that because that was one, the provider that approached us is dealing more with the skilled nursing facilities and those long delay transfers, you know, and so that's where we started. Now that we have some more interest in it, is hopefully next fiscal year, next time around, I can approach the hospital. Because I know in our stroke committees, over the last year and a half that we've been working with our stroke community, that's always been one of the biggest issues that they've raised, is that transfer.
20 years, yeah.
Yeah, getting one of those. So it's not a dead issue as far as I'm concerned here in Sacramento, and I would keep working to get it.
Dr. Klingman, could you tell us more about the 14-year-old and whether that was a unique case or whether that's part of the trend that we hear about with younger and younger patients having strokes?
So I'm on, and this kid was out playing in the playground, and his mom brings him in for stroke symptoms. And he's got no risk factors identifiable other than he was huge. He's 240 pounds or something, 14-year-old. His dad had died in his 40s of an MI. But as far as I can tell, I just looked at it this morning, or I was looked at it last night, so I was on stroke shift. And I don't think they really found a particular cause for his actual stroke. And I think it leads to an interesting observation, which I think is worth knowing. The rate of stroke has gone down, except in the younger patients. And it appears that the rate is going up in the younger group, and it's traditional stroke risk factors. So it's nothing weird, it's just hypertension, diabetes, hypercholesterolemia, smoking, but in a younger group than we ever saw before. I suspect it has a lot to do with the obesity and the attendant problems and diabetes that comes from the obesity increasing your risk, and so it's super interesting though. Yeah, it shook me up. Yeah, oh God, he got activated. He had an A2 occlusion, and actually I talked to the interventionalist. He actually went up and tried to did a clot retrieval on it, but he got treated with alteplase. Mom was a little reluctant because they said, well, you know, it hasn't really been studied. I had to talk to the pediatric neurologist because it's like Nobody's really done it over 18, and they had discussed it and decided it'd be good to go. Mom was a little reluctant, so I actually managed to shoot up both a CTA and an MRI before we did the treatment, because Mom didn't want to treat unless she knew it was a stroke. So probably didn't hit my 30 minutes, but it was pretty fast. I'm sure it was within 45. And it was based on that A2 occlusion that I said, it's definitely a stroke. Because the guy came in and he was like weak in his leg more than his arm, and it wasn't your typical where it's super easy. But yeah, I'm still kind of, as you can tell, I'm kind of shaken by this, 14, only, oh my goodness. I mean, anybody younger than me has a problem. Yeah, I see these people in their 40s, like, you're so young. These people in their 50s, you're so young. Now, see people in their 60s, it's like this young guy.
So, Kwan, we have a fairly good situation where we're surrounded by hospitals that can do full comprehensive stroke therapy. Is there anything that Sacramento County needs that we should be looking for to develop as we go forward?
Sure. You know, in terms of like things that we should actively work for, like, I think all the hospitals in this area, I think we're lucky enough that we have 4 big hospital groups in this area, and they're all capable of doing like all the things that we would expect from a comprehensive stroke center, a thrombectomy capable center. I think things that we could do better are like transport for cases that need a higher level of care. I think even moving within the area of Sacramento from a smaller hospital to a slightly larger hospital, that's always been an issue in terms of being able to get those patients from one place to the other. I think the other thing to kind of think about is that I think thrombectomy has really made like everything else more prevalent in terms of thinking about stroke. And I think that's probably one of the big things about thinking about TPA now versus 10 years ago is like in the last 5 years that there's been a resurgence in the way that we think about like treatment of stroke in general. With that said, like being able to screen patients better, being more consistent about like seeing patients outside of that pre-hospital stage is going to make a big difference in terms of getting those patients to the hospital. And actually, pre-notification in general is like getting that patient ready when they get here to the hospital to have treatment is going to make a big difference in terms of time. So, which is where like Sacramento EMS Agency and the Sierra-Sacramento EMS agencies are going to make a huge difference in terms of what we do. Like, I think you mentioned a little bit about like having pre-hospital devices, and that's something that's going to happen eventually. I think like we're testing one in the pre-hospital stage right now. There's another device that we're potentially testing just to see if we can have a better hold in terms of whether this is a stroke or whether this is a large vessel occlusion. Like something that he mentioned was like and you guys mentioned was that there isn't a biomarker now, but there are biomarkers that we have, like panels of biomarkers that we use to identify stroke, like after they get to the hospital. And at some point, you can imagine that those markers potentially could be used in that pre-hospital stage. As soon as that technology gets to the point where you can actually screen that patient quicker. I think right now there are gene array studies that basically people are doing, looking at wide range of genes. But like, as soon as that technology gets to the point where you can identify like those genes and they're like more from blood in a more rapid fashion, we may have a biomarker that would suggest, like highly suggest that this is a stroke compared to something else. So you mentioned AI. I think that in the future there is a high probability that we're kind of moving in this stage where imaging was not a biomarker up until a few years ago. Time was in symptom onset, what the symptoms were. But as we kind of move forward in terms of time, like other things will come into play, like devices in terms of looking at things outside the hospital. Like biomarkers will become increasingly more important, and all those things will actually really push us in this direction where, like you guys were maybe, 10 years ago where you guys were lacking, like in terms of compared to today. I think in 10 years from now, like our ability to kind of really identify patients will really change. So I think the most exciting thing is that like it's really evolving over like a very, very rapid fashion, particularly in the last like 7 to 8 years. So
this is a wonderful era of innovation in stroke, and yet we have in Sacramento, you all have at your places, the data on the fact that Sacramento has a higher incidence of stroke and heart attack. We are a hotspot here. We also have a higher incidence of death, and this is across all ethnicities. So we also, at the same time, have a